Well, there's a lot of clear education that needs to go on regarding toxicity management and monitoring. Each of these novel agents have their specific toxicities. And while in the academic setting, we have a lot of experience managing large numbers of bladder cancer patients, in the community, there's a little less experience. And each of these toxicities do need management to keep patients on treatment. Enfortumab vedotin is a very excellent drug. It works well in bone metastases, improves response, improves survival, yet clearly should be monitored closely, perhaps avoided in patients with liver cirrhosis due to the increased toxicity we're seeing in those patients. We also see their black box warning with Stevens-Johnson's that I personally believe is related to cirrhosis of the liver, as we've observed a close tie of developing those skin reactions in patients with cirrhotic livers or fatty infiltration of the liver. Other agents like Erdafitinib and FGF-targeted strategy, we see the typical hand-foot syndrome that we have experience with, yet the unusual ones like central serous retinopathy, which requires monitoring by ophthalmology. It should be monitored for. If detected, treatment should be held so that patients' vision can return to normal, with most patients able to resume treatment with Erdafitinib. And then Sacituzumab govitecan, which is also approved in breast cancer, seems to be more troubling for our bladder cancer patients. And I've personally chosen to give patients growth factor support due to the high rates of neutropenia and neutropenic fever that I'm observing in our bladder cancer patients. These are all excellent strategies. They are making a difference. We're seeing bladder cancer patients living longer than they ever have before. And as we learn to better control these toxicities, patients will stay on treatment longer and do better with more durable response and survival benefit.